Hello, my name is Isabel and I'm a P4 student at Drake University, and today I will be talking about the medication tacrolimus, specifically its use in kidney transplant. So starting off, I just wanted to review that tacrolimus does have several uses and indications, both on and off label, organ transplant for liver, heart, lung, and then today we'll be talking about the kidney, atopic dermatitis, and then several off-label uses as well. It comes in a capsule formulation, granule formulations, and then a topical ointment as well. Tacrolimus does also carry two black box warnings, the first being for increased risk for developing serious infections and malignancies. And the malignancies were specifically skin and lymphoma malignancies, which were found to be more related to long-term immunosuppression rather than this medication in particular, but they still want you to be aware of that. And also it has an increased risk of mortality in female transplant patients with specifically the brand Astagraph, and that brand is also not approved for use in liver transplantation. So next, looking at the mechanism of action of tacrolimus, it is a calcineurin inhibitor, or a CNI. There are actually two, tacrolimus, which I have outlined in red, and then also cyclosporin. The CNIs work by complexing with cytoplasmic proteins. Tacrolimus in particular binds with FK binding protein 12, and these complexes inhibit calcineurin phosphatase, which results in reduced IL-2 gene transcription and a reduction in IL-2 synthesis, and this in turn diminishes T cell activation. In kidney transplant patients in particular, tacrolimus has been associated with significantly lower risk of allograft loss at 6 months and lower rates of acute rejection at 1 year. And tacrolimus is the primary CNI in many transplant centers due to its more favorable adverse reaction profile. And tacrolimus is used in combination with a purine analog. We have two, azathioprine and mycophenolate, and each of those medications acts to diminish purine synthesis and in turn decrease DNA replication. And the combination of these drugs being used in kidney transplant is important because each drug acts on a different phase of the cell cycle. Tacrolimus inhibits activation, and then mycophenolate and azathioprine inhibit proliferation or DNA replication. So next, looking at potential side effects and adverse reactions of tacrolimus, and I do just want to note that this is not a full list of all of the potential side effects of this medication. These are just some of the notable ones that I wanted to go over today. So tacrolimus can cause hypertension. It does this by reducing the glomerular filtration rate and renal blood flow, increasing systemic and intrarenal vascular resistance, promoting sodium retention, and increasing concentrations of thromboxanes. But when compared to cyclosporin, the other CNI, tacrolimus has been shown to display less hypertension in patients. They do require fewer antihypertensives with tacrolimus as compared to cyclosporin. After transplant, can also cause hyperlipidemia. And then looking at more serious adverse events, specifically in renal transplant, nephrotoxicity can occur induction therapy plays an important role in preventing the CNI, tacrolimus-induced nephrotoxicity. And then the induction therapy treatments can cause the CNI initiation to be delayed until the graft regains some degree of function, and those treatments, we have a couple monoclonal antibodies used for that. Can also cause diabetes in some patients. There are several factors that play into that. Tacrolimus use is just one of them, but looking at other risk factors like BMI, genetics, lifestyle, steroid use. This medication can also cause hyperkalemia, and then with just about any other immunosuppressive agent, also being aware of increased risk for malignancy. For pharmacokinetics of tacrolimus, first looking at the absorption, I just want to note that this medication can be administered with or without food, but absorption is decreased by a high-fat meal, so making sure patients are aware of that. Distribution, this medication does cross the placenta, and it is 99% protein bound to albumin and alpha-1 acid glycoprotein. For metabolism, it's primarily hepatic metabolism and is a CYP3A4 substrate. With elimination, the half-life is 23 to 46 hours, and it is 93% excreted in the feces. With monitoring of tacrolimus, it is important to ensure that the patient has a therapeutic serum concentration, as lower serum concentrations have been correlated to higher rates of transplant rejection, so you want to make sure that they are in their therapeutic range. Monthly appointments are needed to check serum levels, and often could be even more frequent than that when first starting. With the immediate release medication, if you're using it in combination with azathioprine, have the serum concentrations listed there for months 1 to 3 and then months 4 to 12. And then if you're using it in combination with mycophenolate, they have a separate serum concentration levels there. The trough for oral therapy is drawn typically within 30 minutes prior to the next dose being given, but frequency varies depending on transplant type, time since transplantation, and clinical situation. And finally, just some things to keep in mind, some special considerations for tacrolimus. This is an immunosuppressive agent, as we have said throughout the presentation here, so just making sure patients are aware of that and understand the risks and side effects involved with that, reinforcing the importance of minimizing the risk of infection, hand hygiene, wearing a mask in public, avoiding crowded and enclosed spaces, and then also following up with patients monthly to monitor side effects, labs, and vitals, blood pressure, blood glucose, renal and hepatic function tests like CBC or BMP. Blood pressure can also be monitored 3 times a week for the first few weeks, as it can increase that. Monitoring QT interval as well, as it can be prolonged with this medication. Also, dosing is dependent on immediate or extended release of the formulation of tacrolimus. And that is it. Thank you so much for listening.